And the first speaker this morning for this session is Professor John Prowle from London in the UK. So John is a senior lecturer in intensive care medicine at Barts and London School of Medicine and Dentistry. And he's a consultant physician in intensive care medicine and renal medicine at the Royal London Hospital, Barts Health in London. John?
Thank you very much, Thomas, for the very kind introduction, and I'd just like to echo what a great experience it's been to be here in China, and to thank Jaffron for their hospitality and for sponsoring this great academic exchange. So we're going to begin our discussion of hemoabsorption in the ICU with perhaps what is rather a dry topic, the discussion of anticoagulation in Sorbent techniques. But I think you'll see it's an extremely important topic if we're to deliver a therapy safely, effectively, and consistently to our patients. And so perhaps it's a good point at which to start. So what are our goals in anticoagulation of any extracorporeal blood purification circuit? Because really what I'm seeking to do in this talk is take our existing knowledge from our many, many decades of experience of continuous renal replacement therapies and understand how we might adapt that to a hemoabsorption circuit. Well, we want to minimize circuit downtime due to early circuit loss. We want to prevent blood loss from premature circuit loss. We want to maximize the performance of our therapy. We want to prevent the consumption of consumables and nursing time, and we want to avoid systemic complications of anticoagulation. And if we think about a hemoabsorber, then maybe there is a greater blood volume, they may be more expensive, there may be less expertise in setting up the circuit, and so it's absolutely crucial that we have developed appropriate protocols that allow us to deliver the therapy safely and consistently to our patients. And this involves some form of anticoagulation. I don't know if you know who this gentleman is in the slide, but that is Virchow, who first described a systemic approach to the understanding of blood clotting. And you'll be aware that blood clotting involves an abnormal surface, it involves abnormal blood flow characteristics, and then it involves the activation of the clotting system. And so actually, this talk will focus on anticoagulation, but 2/3 of the work has been done for us by Jaffron and other manufacturers by optimizing the surfaces of their membranes and the characteristics of the packing of the beads that they have, and optimizing the cartridge, the containment system, in order to obtain the best blood flow characteristics possible. And without all of that technology and engineering advance, no amount of anticoagulation would be effective at allowing us to deliver a therapy. And so just to re-emphasize this point, if we want to maximize circuit life, well, we do want optimal anticoagulation, but consistent blood flow and an optimized extracorporeal circuit both outside and within the cartridge is extremely important. I'm not going to talk about vascular access anymore in this talk, but it's very important to note that to deliver effective CRRT in the ICU, appropriate vascular access is absolutely essential. And the same thing applies to hemoperfusion or hemoabsorption techniques, and one should not miss that most important first step in our pathway. But nevertheless, if we move forward to thinking about anticoagulation, and these are goals that have been set in a slide from Ravi Mehta for CRRT, but exactly the same thing applies to hemoabsorption technologies. What do we really want to do? Well, we want to maintain patency of the extracorporeal circuit, and this is not just to prevent overt clotting of the absorber or the circuit, but it's also to maintain the efficacy of the actual membrane characteristics during the therapy. That would be for a CRT type therapy, its use as a dialyzer or filter for exchange, but for absorber in terms of the actual characteristics of interaction with the dissolved solutes that it's going to absorb from the liquid phase. We obviously want to avoid or at least minimize systemic anticoagulation to minimize bleeding, abnormal coagulation parameters in our patient, and the effects of platelet dysfunction on our patients. And we also want to provide an optimal inert surface for blood membrane interaction. We want to optimize biocompatibility, and we want to facilitate the molecular interactions between the target solutes and our membrane. And that will be impaired if we have microthrombosis in our system, we have altered circulation with our system, and that may be very unpredictable and result in inappropriate delivery of therapy. We have some anticoagulation recommendations for CRRT provided by Kay Digo some years back. These will be revised in the forthcoming years. But this is really all we have to rely on in hemoabsorption, and they suggest that citrate may be the optimal anticoagulation, but heparin is an appropriate choice for those who have not fully developed citrate or don't have it available, and they emphasize the risk of bleeding. But they give very little guide about how to give this in CRRT, let alone in a more novel technology like hemoabsorption. At its most basic, hemoabsorption circuit will be a single pump and a Sorbent cartridge with a blood flow through it. But obviously this provides some challenges in how we provide anticoagulation in terms of access and monitoring, and we perhaps have less information about the performance of the Sorbent cartridge because we just have pre and post filter pressures. We don't have any kind of a surrogate of a transmembrane pressure that we might have during a hemofiltration therapy that would give us some operational parameters about how the membrane is performing. We've got to think about these hemoabsorption membranes and how they perform. They're obviously designed to interact with molecules through the forces that Claudio elegantly explained earlier. Very importantly, they have massive surface ratios, so there's a huge volume for interaction, but there is also a huge volume for potentially adverse interactions, including activation of the clotting system. And it's also very important to note that no sorbents are the same. They're classified according to their various pore sizes, and in fact many sorbents will behave very differently and thus have different, potentially different requirements for anticoagulation. And so when we try and take information that we have from doing hemodialysis or hemofiltration, where we have a membrane with separating two liquid phases, when we have an absorber, you will appreciate we have vastly higher surface area. We're actually looking for adsorption of solutes onto this physical matrix, and therefore the interaction with the clotting system may be very different, and there may be much more opportunities for the development of thrombosis and microthrombosis within the circuit. And just to emphasize, there are many different Sorbent systems, such as a few of these from Jaffron here, and they have very different characteristics, and therefore they are going to behave very differently with regard to components of the clotting cascade, which obviously in their own right have various molecular weights. And as you're well aware, the sorbents are packaged into cartridges, and as emphasized earlier, the packing of the beads and the flow performance through the cartridge and its housing is extremely important in terms of maximizing the efficacy of the device in terms of blood flow and the prevention of clotting, and a huge amount of work has gone into that. And what we need to do is just optimize then the blood so it works best with the cartridge. And of course, there's not just around the beads, there's potential flow within the beads. Cells may not get into the beads, but certainly plasma will, and have the potential for activation of clotting mechanisms depending on both sort of within large bits of structure of the beads and even in much smaller areas depending on the molecular weight cutoff of the pores within the bead surface. It's also undoubtedly true that we can provide hemoabsorption in a variety of different setups, and the anticoagulation requirement for just a pure, as we might have said in the past, hemoperfusion therapy may be very different from that in combination with a CRRT as a continuous dialysis or a filtration technique. And that's because obviously a more complex circuit, different requirements for blood flow rate dependent on the CORT device, but also perhaps opportunities with the CORT device to give forms of anticoagulation such as citrate, which might be slightly more technically difficult to give with an isolated sorbent cartridge. And then, of course, we have things like CPFA or DP mass type therapies with more filters involved, more complex circuits, but then, of course, we have plasma filtered the blood, and so we have plasma, which may have the tendency to clot, but without cellular components, including platelets, and this may have very different performance, need different forms of anticoagulation. But of course, if we're doing plasma filtration, don't forget that we may get significant hemoconcentration, and you worry about blood clotting related to that as the more concentrated blood flows from the plasma filter to the dialyzer. And obviously, all these different therapies have very different target blood flow rates overall. A hemofusion cartridge in combination with cardiopulmonary bypass, you may be placing 700 milliliters a minute of blood flow through it. That's very different to if you're combining it with a citrate anticoagulated CORT circuit, where the blood flow may be down to 150 mils a minute or below, and that will provide vastly different characteristics in terms of flow through the absorption cartridge and the level of duration of contact between the clotting factors and surfaces. So here are the issues, in summary, of anticoagulation and hemoabsorption: complex flow characteristics, perhaps an inability to easily monitor membrane fouling and clogging. We've got no kind of equivalent of transmembrane pressure as you might have during hemofiltration. There is perhaps a specific potential thrombocytopenia with some devices that may need to be monitored, and many of the patients we apply this therapy to may have specific bleeding risks in their own right. So we need some anticoagulation options, and probably no anticoagulation is not an option, unlike in some other extracorporeal therapies, because we have this much more complex flow through the cartridge, potentially much slower flow through the very large surface area of the cartridge. It's like a small stream which is running rapidly, going into a wide river that runs much more slowly, and it's in the wide river of the cartridge where clotting may occur. And so we need to think about an option, and that may be unfractionated heparin, and that's probably where the most experience is, and then we have to think about how we're going to target that. It might be low molecular weight heparin, it may be citrate. There are some other options. Serine protease inhibitors such as namphostat mesylate have been used quite extensively in Asia, and they present quite an attractive option. However, I don't have any experience of their use at all, and so I'm not going to speak anything further about them other than to remind you. And then there are, of course, some other options that we may use in specific patients, such as direct thrombin inhibitors. Prostacyclin I don't think would be suitable for use alone, but might be an additional agent one could think about if one was particularly concerned about platelet consumption. So heparin, how might we use that? Well, obviously if you're giving an ECMO circuit, you'll have relatively high dose heparin. It's usually targeted to an activated clotting time, and then if you're adding in a hemoabsorber, that may be perfectly sufficient for that. Standalone hemoabsorption circuit, well, what do we do? Do we follow CORT advice, which might be to give a bolus followed by a continuous infusion into the arterial limb of the circuit? Some people actually target an APTT in the patient of 1.5 to 2. My practice has always been to give a decent dose of heparin and then aim that my patient is not systemically anticoagulated, but if circuit performance is good, I'm anticoagulating the circuit, not the patient. And so I'm not so concerned that the patient's APTT is above a certain area. I want to make sure enough heparin goes into the circuit to get performance, but that the patient doesn't get systemically anticoagulated. But for a cartridge, it may be a different device. Certainly, priming is extremely important with these cartridges, and I would urge you to follow the manufacturer's advice. And then we would start off with initial dose and potentially vary that according to performance. There are some suggestions for monitoring. from a variety of different manufacturers. This might involve the ACT, which has a point of care and is available in many cardiac units and therefore is attractive there, or it may involve the APTT, but you will see that the recommendations for APTT are a bit more towards the systemic anticoagulation side. And obviously our options for monitoring are really looking at the activity of factor 10 and 2 with APT and ACT, but there's also the option for anti-10A activity, which is more specific for the heparin activity and is very good for the low molecular weight heparins. And so these are the kind of the options that we have available to us, but they're imperfect reflections of what's going on inside the circuit. So low molecular weight heparin has got now very widespread use in intermittent hemodialysis, often without any form of monitoring. They just give a bolus dose and give the dialysis and adjust if there is a potential pattern of circuit loss. But you can monitor by this heparin assay or anti-10A activity. The problem is the target range varies according to the form of heparin you're using. It's very different from our fractionated heparin to low molecular weight heparin. In intermittent dialysis, again, you can give a bolus, but CRT protocols have usually used a continuous infusion of low molecular weight heparin, which kind of perhaps offsets some of its advantages. And there are case series of its use in hemoabsorption. There are many different protocols targeting anti-10A activity levels. The advantages are it's perhaps more effective and better, more predictable pharmacokinetics and lower complications, but reversibility is more tricky and anti-10A activity is not available everywhere. Citrate is, of course, perhaps our gold standard for the application of CORT. This cartoon here kind of represents a generic citrate circuit, but obviously our aim is to lower the ionized calcium within the extracorporeal circuit to, to a level where thrombosis does not occur. Everybody shows this slide, which is from many years ago, which shows an electromicrograph of the adequacy of citrate, but it's important to reflect that we now have 30 years experience of use of citrate, and it has consistently been associated with far better performance of our extracorporeal circuits during continuous renal replacement therapy, and really is well established as the gold standard. And of course, lowering of the ionized calcium reduces or eliminates the effectiveness of the calcium-dependent clotting factors, which are very much those targeted normally by warfarin, and renders very effective regional anticoagulation as long as you get the calcium level down to the appropriate level. And we've got lots of data to show that in meta-analysis that citrate is associated with longer filter survival in CRT and less bleeding complications. And so if we can apply this to hemoabsorption, I think we can be confident that it would give us the optimal strategy if it was available. It's certainly safer, and metabolic complications and symptomatic hyperglycemia are not significantly encountered in modern protocols with appropriate monitoring. Although I would remind you that all studies were performed in excellent expert centres with well-developed systems, and it's not something you can just go and apply without some thought. There are many different ways in which you can deliver regional citrate anticoagulation, even in CRT, and so you'll need to consider very carefully how you're doing it with hemoabsorption, what modality of therapy you're combining it with, and how you're going to deliver the citrate, the calcium replacement in its monitoring. It's fair to say that with hemoabsorption, regional citrates have been mostly used in combined circuits with conventional CRT, in which case the citrate doses depend on the blood flow rate, and you generally use blood flow rates up to about 150 millilitres a minute to accommodate that process, but usually not higher. And so there is a dynamic tension here about wanting to optimize blood flow for effective hemoabsorption and not to do too high a blood flow rate to avoid excessive citrate use. That might be a potential limitation. There's little or no data of standalone use in hemoabsorption or calcium requirements in that modality, and so I think that there's no reason why we couldn't do it with appropriate monitoring, but it would need a development package to kind of understand the operating performances of that. And so at the moment it's mainly confined to combination with CRT. So to conclude, hemoabsorption circuits may have a greater immunogenicity than conventional CRT circuits because of the kind of physical characteristics of the device, its size, how we're using it, and also the fact they're also often used in combined circuits, and the more complex the circuit is, the more higher the risk is for clotting. It's also true that when we look at the cartridge, we can look at the pressure going in and the pressure coming out, but it's very difficult to understand what's happening within the cartridge. It would be very interesting to do further research on this, but it does mean that we perhaps want to make sure that we are really optimizing the anticoagulation, because we can't easily tell when it's going wrong, and it might be that flow through the cartridge is preserved even when the actual operating characteristics of the membrane have been significantly compromised. We've got to be cognizant of bleeding risks and the specific hazards of thrombocytopenia, which we should monitor. Anticoagulation using citrate may be optimal, but it does require at the moment the use of a CRT circuit and the development of a specific protocol. And if you're using heparin, slightly higher dose may be required than in CRT, but you will need to review that with the performance of your individual therapy. And with that, I will conclude.